Picture this. You're on the clinical wards, standing right at the bedside of a patient who's suddenly struggling to breathe. You pull out your stethoscope, listen to their chest, and you realize fluid is abnormally accumulating right there in the pleural cavity. The immediate questions for us as clinicians and medical students are pretty straightforward. What kind of fluid is it, and exactly why is it there? Welcome to today's Explainer, where we're going to master pleural space diseases and really sharpen up those bedside diagnostic skills. All right, here's our clinical pathway for today. We'll start with an introduction to pleural effusions, followed by differentiating transudative versus exudative effusions. Then we'll cover primary bedside clinical signs, diagnosing and managing these cases, what happens when fluid becomes empyema, and finally, pneumothorax, when air enters the pleura. Section 1, Introduction to Pleural Effusions. Now, normally, the pleural cavity is this incredibly thin, tightly regulated space with just a few teaspoons of lubricating fluid. But in an effusion, excess fluid abnormally accumulates. Whether your patient is completely asymptomatic or presenting with severe dyspnea and sharp pleuritic chest pain, our primary job is to find the source. Broadly speaking, we classify the cause of this fluid into two main camps. On one side, we have systemic causes. Think of this as a broad mechanism of systemic fluid overload or pressure imbalances. And because it's a systemic issue affecting the whole body, the effusion is typically bilateral. It's equal on both sides. On the other side, we have local causes. This involves localized inflammatory factors that directly alter the permeability of the pleural surface itself. Because it's a local problem, these effusions are typically unilateral. Section 2. Transudative versus exudative effusions. Okay, let's dive into this. That systemic versus local distinction gives us our ultimate bedside cheat sheet, and it's the key physiologic differentiator that defines our entire approach. Check out the pathophysiological differences here. In a transudative effusion, we're dealing with a systemic fluid overload. The blood vessels are actually completely intact, but they're leaking a watery, protein-poor fluid purely due to pressure. That is why the protein content is low, typically less than 2.5 to 3.0 grams per deciliter. You're going to see this in conditions like congestive heart failure, cirrhosis, or nephrotic syndrome. Now, contrast that with an exudative effusion. Here, localized inflammation, infection, or a tumor has caused damaged and leaky blood vessels. This allows protein-rich fluid and cells to just freely escape into the pleural space, pushing that protein content high to 3.0 grams per deciliter or more. We see this with pneumonia, malignancies, tuberculosis, and pulmonary embolisms. Beyond the protein content, I really want to emphasize another absolutely critical lab value threshold we use to differentiate these two fluids, the pH level. According to our diagnostic parameters, you need to watch this number closely. Seriously, write this number down, 7.4. If the pleural fluid has a pH of less than 7.4, we're looking at a transudative effusion. But if the fluid's pH is more than 7.4, it falls right into the exudative category. Keep this specific 7.4 threshold in your back pocket when you're analyzing those fluid results. Section 3. Primary bedside clinical signs. Long before we rely on advanced imaging, our hands, our ears, and our stethoscope can tell us a massive amount of information. When you examine a patient with a pleural effusion, you're looking for 4 classic physical signs. First, you're going to notice decreased chest expansion on the affected side as they breathe. Second, and so the crucial point is how this physically feels, you will elicit a stony, dull percussion note. When you tap on their chest, it literally feels and sounds like you are tapping on a solid stone, all because that thick layer of accumulating fluid is blocking the normal resonance of the air-filled lung underneath. Third, when you listen with your stethoscope, you'll hear diminished breath sounds over the fluid. And fourth, both tactile vocal fremitus and vocal resonance are significantly decreased, simply because the fluid acts as an acoustic barrier. Okay, so you've noted the decreased expansion, the stony dullness, and the quiet breath sounds. The physical exam strongly points to fluid. The logical, engaging next question to ask is, what happens when we image this patient to visually confirm our bedside diagnostic suspicions? Section 4. Diagnosing and managing effusions. When we pull up a chest X-ray, this is exactly what we're looking for. Down at the lung base, you can clearly see a classic curved shadow tracking up the lateral chest wall, and this brilliantly illustrates the meniscus sign, which is the radiographic hallmark showing exactly how the fluid physically tracks and sits in the pleural space. Sometimes, depending on the pathology, you might even see a scattered snowstorm appearance. Once we visually confirm this fluid, we proceed to thoracocentesis to draw it out and make our definitive diagnosis. So once we have our diagnosis, management always comes down to treating the underlying cause. If it's an uncomplicated parapneumonic effusion, we hit it with targeted antibiotics for the pneumonia. If it's complicated, meaning we have a positive gram stain or culture, we've got to be much more aggressive. For therapeutic relief, if the effusion is highly symptomatic, thoracostomy drainage should be performed carefully and slowly under 21 days. Other management measures might include pleurodesis with tetracycline to basically fuse the pleural space shut, or even surgery depending on the severity of the underlying condition. Section 5. When fluid becomes empyema. Now, let's escalate the clinical stakes a bit. What happens when that simple fluid becomes complicated by an active neutrophil-rich infection? Well, this is when a pleural effusion turns into a highly dangerous empyema. An empyema is the collection of actual pus in the pleural space, often secondary to pneumonia or a ruptured abscess. And it brings severe systemic features like high-grade fever, rigors, and massive leukocytosis. We get a stark contrast in physical pressure inside the chest cavity depending on the invader. On one side, we can have a lung being actively compressed by the thick, heavy pus of an empyema, also called a pneumothorax. The pus takes up physical space and forcefully pushes against the healthy lung tissue. Contrast this with a pneumothorax, where air has entered the space. The lung isn't just being pushed, the total loss of negative pressure causes the lung to completely collapse inward. To definitively diagnose an empyema, we use ultrasound or a CT scan of the chest to confirm the exact site, followed by aspiration. And here's another high-yield diagnostic number to absolutely lock in for your clinical knowledge: 3.3. When you aspirate that thick, turbid pus, you'll find the fluid glucose drops below 3.3 millimoles per liter, and the fluid pH will be less than 7. This is a massive red flag indicating a thick, active empyema. Because a non-tuberculous empyema is such a severe infection, the management action plan has to be escalated and multi-tiered. Step 1. Start empiric antibiotic therapy immediately. We're typically talking IV cefuroxime and metrodiazole for 2 to 4 weeks. Step 2. Insert a wide-bore intercostal tube. You need a wide tube because, frankly, that thick pus won't drain through a standard catheter. And step 3, if the pus organizes into a fibrous rind, the patient will actually require surgical decortication to physically peel it away. Oh, and if it happens to be a tuberculous empyema, you immediately start anti-tuberculous therapy right alongside aspiration and drainage. Section 6. Pneumothorax. Air in pleura. Shifting our focus entirely from fluid and pus to air, let's move to pneumothorax and see how this builds when we explore a sudden loss of negative thoracic pressure. Understanding these mechanical shifts can literally save a life. We generally categorize pneumothoraxes into 2 distinct types. First up is a spontaneous pneumothorax. The most common cause is idiopathic, often due to the rupture of a subpleural bleb, which pops and produces a hole in the pleura. The lung collapses, and importantly, listen to this, the trachea deviates toward the side of the lung collapse. Then we have a tension pneumothorax. This is often caused by penetrating chest wall injuries or positive pressure ventilation. Here, a flap-like pleural tear acts as a one-way valve. Air gets in, but it cannot exit. This causes a massive, incredibly dangerous increase in pleural cavity pressure. And this time, the trachea deviates away to the contralateral side. When a patient experiences a pneumothorax, the clinical findings are sudden and dramatic. They're going to present with sudden onset dyspnea and sharp pleuritic chest pain. But think back to your bedside exam. Instead of the stony dullness we felt with a fluid effusion, you will now find a tympanic percussion note. It sounds hollow, like a drum, brilliantly differentiating a chest full of air from the fluid-filled space we discussed earlier. Furthermore, when you listen, breath sounds will be completely absent over that collapsed lung. We have covered a massive amount of clinical ground today, from the systemic fluid overload of a transudative effusion to the thick pus of an empyema, right through to the rapid mechanical shifts of a tension pneumothorax. But I want to leave you with this final, provocative clinical scenario to chew on. We can drain the fluid, we can pull out the pus, and we can reinflate the lung. But if we don't treat the underlying systemic or local cause, how long until the space fills again? Mechanical fixes at the bedside are satisfying for sure, but they must always be paired with definitive medical treatment. Thank you so much for joining this explainer. Keep practicing those bedside clinical skills, and I'll catch you next time.